When you think about measurement of digital patient engagement today, the industry really is in its infancy. Look at what's tracked right now in the Most Wired Trends report. Frankly, it's all about the portal. If a patient with a portal account has logged in one time in the past year, Chime counts that patient as engaged. Well, by this standard, 85% of acute care organizations report top performance, meaning that 25% of their patients with a portal account have logged in one time in the past year. This is considered top performance. Really? How often have you logged into Amazon in the past month? It's just not very helpful. I mean, even if I personally wanted information about my health, my local health system, which is an academic medical center, and they are on Epic, has very, very little to tell me through their portal. Case in point, I actually had a liver panel recently with a highly out-of-range value, more than 2 times what it should be. The interface told me nothing. So I did the side-by-side thing, where you pull the result up on one screen and then you pull the Mayo Clinic site up to try to figure it out. And then I actually messaged the nurse, who then sent a message to my physician, adding then more work for my physician, who was going to see that message in their inbox and have to then add to their work queue, all because this digital interface underperformed. And its design lacked intelligence. But my health system can count me as digitally engaged. They can tick that box, if you will. But what was the outcome? What result was delivered? Health systems today are measuring what they do, but really not how well it works or its impact on patients. We're sort of stuck on process measures. I think we can all remember when quality was there. Well, it's time we have to start moving to measuring results. And let's start by building a digital engagement process that uses consumers' preferred technology and engagement channel. Guess what? We're all hooked on our smartphones, even those of us over age 65. And 85% of us want to receive text communications over emails. Well, at Notable, we have built our consumer digital engagement experience on this premise. We measure how many we reach, what proportion engage, and then whether they get through our digital experience, which means there's a result or an outcome. So this is average performance for September 2022. Now, this is average. And I'm not showing the top decile, I'm showing the 50th percentile. We reached 99% of our patients on our lists. 68% of those patients engaged with our digital experience. That means they opened it, they cleared the date of birth match, they started the form. And then 60% actually completed the entire digital experience. That means they had a result. They had a pre-registration, they had a co-payment, they had an appointment confirmation or cancellation, or they had a care gap closed. 95% of those patients gave us a thumbs up. Well, complete candor, we actually can only collect that satisfaction data from patients who complete the entire experience. Well, we don't want just a great numerator, which are the numbers that you see here. We actually also want to increase the denominator, the number of patients who actually start that experience and engage that experience. And here's how we do it. This is a very complicated diagram. I'm not going to walk through it, but it's called a Sankey. And what a Sankey does is help you understand how someone moves through a flow from beginning to end. It's basically just a flow diagram. Where does it start? Where does it end? And you can see how many prompts that basically go out and how many patients do we reach out to, I should say, to start an experience, whether it's an intake or a care gap outreach, a referral and authorization, and then where does the journey end? Well, this diagram gives notable insight into where the experience likely needs improvement. Every time a flow dead ends with an incomplete, for us, that's an opportunity to improve. And one of our tenets at Notable is obsess over outcomes. Well, this gives us the data for really starting our analysis. I'm sure there are skeptics out there who are going to say, well, it's one thing to collect administrative data this way, but you're not going to collect meaningful clinical information this way. Patients can surprise you. This is our conversion funnel for clinical intake solutions specifically. And what you can see here is that we're achieving great results with, on average, 62% of patients completing that clinical intake experience. But there is a drop-off. 71% engage, 62% completed. So now what we do is we pull a drop analysis, and that's what you see on the right. And what this shows you are the candidate forms where patients may be dropping off. Well, patient history forms, payment history forms, it's not surprising. They're long, they're sometimes more cumbersome. MSPQ, it's a regulatory requirement, kind of a dud. No one likes to really answer those questions. And then, mental health questions. Sometimes people are put off by those. So we always have to think about what's the right way to ask those questions. So these are the kinds of questions we ask ourselves when we iterate. And, you can see, is the form too long? Or the questions in the right order? Do we need to create a dynamic form where we add if-then logic to make sure that it gets through more quickly? A couple of observations here. First, when you give patients the time and the space to actually give these forms the quiet focus that they deserve, they get them done, and happily. No distraction because they came in late and they're rushing, or because their kid is sitting there in the waiting room tearing up the People magazine. We've all been there. We all know what it's like. And then second, when this work gets done prior to the visit, you actually free up a waiting room seat, plus time at the front desk to serve one more patient who needs to check in for a same-day visit. That increases your support services staff capacity. And more capacity per FTE means you need fewer FTEs over time. Our customers are reporting before and after time savings at the front desk of between 3 and 8 minutes per patient who uses our intake solution. Well, if you take into account volumes across our customers, that actually comes to an average of 4.2 minutes saved per patient completing digital intake. Here we share what the annualized impact of all of this is at Intermountain. First, the savings from the volume of patients using our intake solution. You can see 2 million patients completing our experience. On average, 4 minutes saved per intake equals 134,000 FTE hours saved for support services role. That actually rolls up to 70 people, if you're doing the math in your head. An interesting fact here, I actually did a search on Indeed.com just 2 weeks ago for entry-level patient service specialist positions in Salt Lake City. Intermountain had 12 openings. Their largest competitor had 79. We're not going to take credit for it, but just thought it was an interesting fact. Here you see annualized clinical staff savings from doing a digital first pass pre-surgical intake. Now, of course, the nurse still has to call the patient to do the intake, but having a form that is pre-filled for that nurse, because we've mined the EHR and brought up the right information, saves that nurse 12 minutes per call. You roll all that up, and you're freeing the time of 14 nurse FTEs annually. Now imagine if in one metro market we used Notable, say District of Columbia. 50% of the encounters went through our digital intake solution. That rolls up to over 500 FTEs saved, which would make obsolete most of the entry-level patient service specialist vacancies listed just 2 weeks ago in that marketplace. Now, of course, they're not all going to go away because we still need people to be at the front desk to check in same-day appointments, but we could certainly eliminate a large number of, or free up a large amount of capacity in marketplaces. Digital engagement before the visit also enables us not just to save time, but also, and to capture better data, but also to capture more dollars. And here what you see is the range of improvement in the percent of payments collected prior to service that is reported by our customers. So we actually track this a little bit differently from the typical point of service revenue cycle metric, which tracks collections at the point of service as well, and then it tracks it as a collection as a percent of revenues. But we use our definition because what we want to understand is when a payment option is given digitally, what proportion of patients actually use it. Well, customers report a range of performance gains on that metric, basically what percentage of patients are paying through a digital solution. Their performance improvement is 40 to 130%. The weighted average of that improvement is 76%. Well, here we just model that before and after when you take into account the notable solution on a population or a health system that has 1 million visits. So across the cohort, on average, 24.5% of patients use our digital solution to pay their point of service collection, pre-visit amount, copay, digitally. Compare that to a before rate of 13.9%. Well, we only expect really 60% of patients to have a copay in this model. So we've created a model here off of 1 million visits. And in our model, where 60% of the patients even have a copay, some of it might be nominal, for some of them it might be $30. But you take all of that into account, and the improvement that you get is over there on the right, and you can see the differential. After notable, $3.8 million, that's $1.6 million in pre-visit revenue that's collected, and just for copays. And you all know that the need for this pre-visit collection only grows. Digital collection alleviates a staffing burden. Staff don't really like to do this. If you could actually capture prior balances as well, you're capturing a lot more data prior to the service. It also provides transparency for patients into financial responsibility, and it eliminates lots of costs associated with statement printing and mailing, or at least some of them. Back to staff capacity and availability. Recruitment and retention are a challenge in the back office too. That's why we are extremely excited about the work that we are doing to support authorizations. And there's a real 80-20 here, meaning there's a ton of quick approval work that can clog up processing like auto-auth. So we leverage Notable's digital solutions to take on that low complexity work. We also take on notice of admissions, or NOAs, where obviously time sensitivity is critical. And these are the time savings that are reported by our customers, anywhere from 8 to 10 minutes per authorization or submission activity. Here I've just annualized early results from Care New England. Here we're only supporting actually auto authorizations for diagnostic imaging services and just for 3 payers, and NOAs at just 2 hospitals. Yet the savings are mounting pretty quickly for them. And then here again, I just take that model and I show you what would it be like if we did this across the DC market. So imagine we're supporting authorizations for just diagnostic imaging and ED admissions. Further assume that only 60% of those encounters require an authorization. We estimate the time savings equivalent to 163 back office FTEs. Well, with health systems nationwide really struggling to fill these roles, these savings allow you to close open recs for talent and generate savings that, of course, then accrue straight to your bottom line. And you also free talent, and I think Kristen and Aaron will share this from Care New England. You free them to really focus on high value, high complexity work, increasing staff satisfaction and engagement, reducing turnover, and hopefully improving staff retention over the long term. Digital pre-registration also has an impact on no-shows, and that, of course, is the unplanned cancellation. So what we did here is we did an analysis to understand the impact of the Notable intake solution on no-show rates, and we analyzed performance, as I said before, across September 22. A couple of insights here. First, no-show rates are actually rising everywhere right now, and that's just a function of the economy, rising out-of-pocket costs, folks postponing care if they are able to. We actually saw this same trend happen in 2007, 2008 when we had the prior economic downturn. But that said, Notable is having a very positive impact, reminding patients of visits and locking in commitments. No-show rates at clinics that where Notable is not yet live, you can see here are 2 times the rates at clinics using the Notable intake solution. We model this here for a system serving 1 million patients per year, and you just see the comparative revenue capture that equates to. On just primary care visits, that's $12.6 million in terms of added revenue. And then if you flip your mindset a little and think of it not as a no-show rate, but as a digital cancellation rate, when you get this notice ahead of time, you actually have the potential to backfill the visit with another patient. If you just backfill 50% of that capacity, it amounts to $6.3 million. I know every health system here today has patients that are waiting to fill every square foot of your available capacity because demand exceeds supply in most markets. And frankly, the move to population health management has only heightened the imperative to pull in those patients to be seen. And Notable is making that possible. Customers are using our digital outreach to prompt patients to close care gaps, whether they are preventive care visits, whether they are recommended screenings. And in doing so, they pinpoint clinical problems early, they manage at-risk patients much more aggressively, and they mitigate the need for acute care medical services that might present downstream. This is just a list of the care gaps that we support today. You can see breast cancer screening, colon cancer screening, diabetic screening, well child visits, Medicare annual wellness visits, and the like. This list is growing very, very fast. And then on the right, what you see is our impact when the patient answers the phone. And what's really interesting here is the rate at which people open our messages right now is on the par with the rate at which they answer the phone. But it's a lot easier for us to send out digital, automated reminders to try to get these people scheduled. Now, even Epic can't do this the way we can do it on a repetitive basis. Epic has ticket scheduling, and you can send out one digital outreach, but you can't send out multiple, at least as what we understand. And then once the patient picks up, we close that care gap 46% of the time. And then we get a visit scheduled on average 9% of the time, which actually beats other vendors in this space. Now let me put this in financial terms. I've modeled out what we could do across a population of, say, 250,000 Medicare Advantage patients, assuming we only have to contact here 40% of them, since many might already have closed a care gap previously, or using our filters in the computer systems, we can filter them out. Well, first, the value-based care bonus dollars from just closing those gaps, I've just put in a very basic assumption here of $12 per gap, but $12 incentive care per gap gets you that first bar. Then, the larger bar is the fee-for-service revenue that you earn when you actually perform the screenings. All told, that's just under $1 million in added revenue. Here, I've added the costs if you do this manually scrubbing the charts, manually calling the patients, manually scheduling the visits. Now remember, if a phone gets answered 30% of the time, you've got to call that patient 3.3 times to get that care gap closed. That's a lot of work being done by talent and high turnover roles. Clinical care coordinators to scrub those charts, schedulers to do those calls. And the costs just end up far surpassing the financial gains. And when you don't have that talent, it's an onerous burden to try to get this work done, even if it is clinically right answer. But if you can put digital assistance against this, it gets done easier and it gets done faster. And we are continually iterating to try to figure out how to do this better. Let me just summarize here the value of the digital care gap outreach. First, as I said, digital assistants can do this. They can do this really well. Second, staff are happier for not having to take on this time-consuming effort. Patients get access to care more quickly through a personalized outreach that meets their unique healthcare need. Put all of these outreach capabilities together, and you can see the larger opportunity here that Notable presents. What we find too often is that our customers unintentionally have organizational stakeholders working at cross purposes when it comes to the patient. When every service line or every clinical department or even every function has its own digital approach, it creates a lot of friction and noise for the patient. And you likely then have data coming into your organization but going into silos, into duplicative systems that require staff to then manage work queues downstream to reconcile all this data and get it into the electronic health record. Well, today, with our customers, we are helping to align these departments around the patient. We push our customers to bring the entire team together, the administrative part, the clinical players, to ask what's best for the patient and what is most efficient for our enterprise. And let's deliver the most holistic digital experience that we can. Consider the gains when you can basically have, with just a click, a patient prompted to easily deliver you the right data in the right format. And then with another click, have our AI actually put that data directly into the electronic health record. And again, we're constantly iterating to improve and do this better.